record only the class. Okay, fine. So any other possibility? It could be because of the drug. Have you seen the patient is on treatment, on thiazide, hydrochlorothiazide treatment, and even AC inhibitor? So because of the hydrochlorothiazide, most likely there is a possibility of actually like loss of slight level of sodium, yes, through diuresis. So that is one possibility because we don't know when they have done this measurement. We don't really know whether, because the patient is still on treatment and they measure the electrolyte level, but this is one possibility. Okay, what do you think about the low potassium level?
Excuse me, sir.
Yes.
Before we continue, was this investigation done before they were given the treatment, or the treatment is the one, the current treatment? I thought the current treatment is the one the patient will now continue with after the investigations.
Yes, in principle it is like that, but it could be like the current treatment can be a continuation of the previous one. Because this is a
Okay.
chronic hypertensive patient which has been treated before. So then, unfortunately, at some point, the patient was admitted because of this condition. Then when they are admitted, then they measure those electrolyte level and they normally give this treatment. But we don't have like prior information whether the patient has been on those medication, but most likely the patient has been on those medication, like based on the history.
So,
Yes.
but in the past medical history, the patient was receiving only augmentin and another drug for anemia.
Only, yeah. Okay, but maybe I don't think so, by the way. But have you seen normally the past medical history of the patient? The past medical history of the patient, hypertensive since 2012. So do you think normally this patient is not on treatment? So that is why when you're actually writing the patient's information, you need to have like all information in totality. Otherwise, it is very hard even to make decision like for this kind of discussion. So
I have a question. Why is the patient being given hematinic for anemia?
hematinic. Do you know what is hematinic, sir?
No, not really.
Those are like those are drugs like supplements, like the combination supplements, like the vitamins, the folic acid, yeah, supplement and iron supplements together. It's just like a combined preparation for a patient who is having anemia. So despite we don't have a result about the parameter, most likely we are expecting anemia when a patient is having end-stage renal disease. So most likely it is just because of the anemia.
Okay, thank you.
Okay, huh? Okay, any other question?
Sir, it's a random question. Is it possible to have dehydration and edema concurrently?
Very unlikely. Because how can we say normally dehydration? Dehydration
Okay.
and what? You say dehydration?
And edema. When
No.
Angela was doing the breakdown, she talked about the patient was dehydrated. So I didn't understand where it was coming from.
Very unlikely. When you say dehydration and edema is very unlikely, you are saying no. Even the clinical presentations are actually different. So dehydration and edema cannot happen concurrently. Yes. If the patient is dehydrated, we don't really see like an edema. But remember, when you say dehydration, we're just referring like loss of water.
Yes.
Okay. Any other? Okay, so what do you think about like the loss of, okay, what do you think about the possibility of having low potassium level?
As a result of vomiting.
Yeah, I think that is the result of vomiting, most likely, because even the gastric fluid contain normally like a slight amount of potassium. So it is says from the literature about like 10 milliequivalent per liter, milliequivalent per liter. So that is the most likely causes like for this patient about the low potassium level, or it could be even dialysis. The patient has undergone dialysis, I think. Was it mentioned elsewhere? I think the most likely this patient has undergone dialysis. I have seen intradialysis transfusion has been done. So it could be even the dialysis. It could be actually because of the dialysis, the patient is having low potassium level, or it could be actually because of the vomiting. Okay. Then have you seen about the chloride level? The chloride level is slightly, it is actually elevated if the figure is really correct. Huh? So what are the cause of actually chloride imbalances? Mostly dehydration can actually cause hyperchloremia, and even when a patient is actually having a problem, that can cause sodium retention, like kidney disease, and even Cushing syndrome. They can actually increase the risk of hyperchloremia. So that is another issue. You know, the major problem with chlorine, when the chlorine level is high, it can actually bind with potassium and increases the risk of even metabolic acidosis. So for this patient, I think, I don't know, it could be, it's very hard to say what really causes high potassium level, but I think it could be like because of the kidney problem that is causing retention, but on the other side, the sodium level is really very low. So it's very hard like to make a conclusion in ways. It is very hard to say conclusion because the sodium level is low and the patient is having high level. So it is really very hard to make a conclusion unless maybe the patient is not taking maybe like a lot of water. If the patient is actually restricted fluid, most likely it can elevate the chloride level maybe kidogo. Otherwise, here it is very high. It is very hard to make a conclusion the chloride level is due to this reason. Okay.
Excuse me, sir?
Yes.
Can I say the chloride is elevated because of compensatory metabolic acidosis?
Okay, because the patient is losing hydrogen, so we need to have like that acid-based analysis, like the ABG analysis, in order to even say like that. You know, that is why unless we do have all the lab parameter, it is very hard to say. There is a possibility, but we need to have like the ABG result, whether there is a compensation or not. Otherwise, it is very hard to make decision. Okay, good observation.
Sir, excuse me.
Yes.
We have said that the sodium levels are low, right?
Yes.
I mean the potassium levels.
Yeah, the potassium level is low.
And why in the current management they are restricting food rich in potassium? Aren't we supposed to increase it since it's low?
Food rich, yeah, it is low by the way. Yeah, okay, that is not really like a proper strategy even. Have you seen even the use of enalapril by the way? Yeah? The ACE inhibitor in this renal disease, they are not recommended. They are not recommended by the way. But some physicians, they argue that the kidney has already failed, like is no longer working. So what is the essence of actually giving enalapril? But so far, there is no evidence about the role of enalapril in the end-stage renal disease. But for CKD in general, we can give because it reduces proteinuria. But if the patient is actually have failed a stage 5 CKD, there is no role of ACE inhibitors or ARBs. So mostly they're supposed to use like the calcium channel blocker in managing hypertension in this patient population. So, okay, you are right, by the way, the potassium level is low, but the kidney is no longer excreting potassium because it's already failed. So you can actually, when the potassium level is very low, we don't really know what really causes low potassium level in the first place. Like the point of this discussion is just like look at the information in the comment. So restrict potassium food diet might not be an option when the potassium level is low, but you just give kidogo potassium rich diet but you closely monitor because the kidney is not eliminating excess potassium level. So there is a possibility of high risk. So restriction is not an option, but you have to give potassium.
Excuse me, sir.
Potassium is low, yes.
I think according to the investigations, the potassium is 28.
No,
it's
it
high.
is not. Is it 28 or not 2.8? Hey, 28, potassium 28, it cannot be. By the way, when that level of potassium reaches, the patient are already dead. I've never seen a potassium of 28, like in the past how many years. So like even severe is like above 7 is even a medical emergency. So the moment the patient is having 28, they have actually cardiac arrhythmia and the heart is no longer working even. So I think it is 2.8 if there is an error, or maybe 3.8 or 2.8.
So,
Okay, it seems like 228, but I don't think so. I will not actually believe this result. If you see a potassium level of 228 in a live patient, very unlikely. I think with this potassium level, if you actually give potassium chloride intravenously in normal individual, you can even kill the patient because of hyperkalemia. Hyperkalemia causes hyperpolarization, cardiac depression, and the patient will die immediately. So it's very unlikely. Okay, thank you for your. I've seen it by the way, but I didn't trust like that result. I thought I considered as 2.8. But anyways, I think the whole idea is just like to see you will encounter like a very complex condition even in the lab parameter, and sometimes even you'll find in your like in hard place to make decision. What will happen if I do this? If I do this, this will happen. If I don't give this will happen. So this is how like the clinical perspective look like.
So,
yes.
When we were doing the question, I saw that the reason for restricting fluid intake and food rich in potassium, it's normally recommended when a patient is undergoing dialysis.
Yes, why? Do you know why?
Not really.
Because the dialysis fluid, the dialysis, it contains even potassium, chloride, sodium. It actually contains the normal physiological electrolyte. So during dialysis, normally those things are not recommended. Yes. So if that is the case, normally that you are right, during dialysis, we are not even replacing, even by the way, when even a patient is having maybe metabolic acidosis, we don't even give sodium bicarbonate supplement during dialysis because the fluid contains even sodium bicarbonate. So we have to hold. But anyways, so anyways, when you look at the treatment, even in fact, the information is not adequate in the first place. Like we don't really have sufficient information. So what do you think about the management? Is it really adequate to control his BP? Do you think it is adequate to control the blood pressure? In fact, we don't have like the current BP of the patient. What is your observation? Even hydrochlorothiazide, have you seen like 125? No, this one is like 25 milligram, not 125, because the maximum we can give is like up to 100 milligram OD. So this one is not even correct. So you'll see like so many errors when you are reporting those information. So
maybe it's 12.5.
Is it 12.5? Okay, but there is, I didn't see the point. I didn't see the point anyways. Okay, good. Okay, anyways, okay, in the first place, there is no evidence about enalapril about the efficacy of ACE inhibitor in controlling hypertension in end-stage renal disease. So this one is supposed to be corrected. I don't have objection about hydrochlorothiazide issues, but instead of enalapril, maybe amlodipine or nifedipine extended release, which is available locally, can be recommended. But of course, anemia CBC result is mandatory to make decision whether the patient is having anemia or not. And dialysis like two sessions per week is usually recommended if the patient is actually can afford. So in fact, they say that hydrochlorothiazide should not be given in stage 4, but it must be given in loop diuretics. Okay, oh, good. That is good observation, by the way. If the GFR is less than 30 ml per minute, this is not an effective diuresis to control the blood pressure. I forgot by the way to tell you. So when a patient is having an edema, and if the GFR is actually less than 30 ml per minute, the most effective diuretics is actually loop diuretics. So that is very, very important. They say GFR test, but do we have a test for GFR? Do we have a test for GFR? The group members, I hope you have actually discussed vigorously about this issue. The group members. Do we have a test for GFR? GFR test, Makina. Venisha, you want to try?
Yeah, so there is a test.
There is a test for GFR.
Yes.
What do you call that test?
The glomerular filtration rate test.
Okay. Okay, but anyways, like there is no apparatus that actually tests GFR. What you can do is you are going to calculate based on MDRD formula or maybe Cockcroft-Gault equation. You calculate the creatinine clearance. So what you need is actually the serum creatinine and of course age of the patient and weight of the patient. Those are the only parameters you need. Otherwise, there is no like any instrument that can calculate the GFR of the patient. You are the one who is supposed to calculate based on the creatinine clearance, age, and gender of the patient. So MDRD formula is the latest one because that is more reliable, but I've never seen when they are using it. But Cockcroft-Gault equation is the most commonly used. Then give erythropoietin stimulating agent for anemia. Yeah, it can be recommended, by the way, but depending on the level of hemoglobin. If you remember, we need to look at the hemoglobin level, and if it is above 10 and above 11, don't give ASA because of what is the risk of ASA? You are feeling you are discussing about cardiovascular. Yeah. Yes, coagulation is actually the risk of clot formation is very, very high because it enhances viscosity of the blood. You are feeling normally you are discussing about cardiovascular and renal disorder, but those are the common conditions as compared to the endocrine disorder. Those are the common conditions, and I decided like until we start, we are supposed to discuss those kind of activities. Okay, good. So they have not said about the follow-up result and the monitoring parameter, but the monitoring parameters are the one. What monitoring parameter are we going to use? The serum creatinine, potassium, blood urea nitrogen, then fluid like input and output, like the weight of the patient, so that we can actually measure. Then, of course, clinical resolution will be, you will see like the improvement in the clinical parameters. Okay, so maybe do you have any question about this very complicated and not complicated?
I have a question. I'm not sure if I'm taking you back, but on the issue of using ACIs in end-stage renal disease, if I remember correctly from class, we had mentioned that they're renoprotective. So my question is are we avoiding it because at the point of end-stage renal failure, there is not really much you can do apart from give transplants because you can't improve kidney function pharmacologically, or is it that the risk outweighs the benefits when you're giving angiotensin-converting enzyme inhibitors?
Good question. So based on like the recent information, there is no evidence about the efficacy of the use of ACE inhibitor in the stage renal disease because the kidney has already failed. The kidney has already failed. So the recommendation is they are renoprotective. Of course, if the patient is having stage 1 to 4, you can give ACE inhibitor because they are actually like very, very important drugs to control, to prevent progression of the disease. But despite they are renoprotective, when the serum creatinine is very limited, like at this point, you have to even, you are not supposed to give them because it can actually worsen the condition because they are actually reducing the GFR. That is the major issue. So the main reason they are not recommended in end-stage renal disease is there is no evidence about the efficacy of these drugs in end-stage renal disease.
Okay, thank you.
So the recommendation, even from the international guideline, so if a patient is having that condition, end-stage renal disease plus hypertension, you just give calcium channel blockers instead of like ACE inhibitors or ARBs. Okay, good. Any other questions? Okay, so you just actually try to recall what we have discussed in the previous semester, which is very, very important when you go back. Then group 4 members. Now, I hope you are in now because now we are 46. So it's only for a student who is not available in the meeting. Group 4 members. Is there anyone from the group 4 members? Okay, fine. So if they are not available, now, like today, in the next an hour, I will give you like to discuss only one case studies. Then at 11, you do have group exercise. You're supposed to do it on Blackboard. It will be active as of 11. Like as of 11 up to midday. Then you are going to do case studies, then you submit. Then at midday, you are supposed to submit the report through Blackboard. Then I will going to mark it out of 10. That is why at the beginning, full attendance is mandatory. So if there is no any members from the group, don't try the name. In fact, even I can check. You can actually remind me whether the members are not available for the discussion. I can see from the attendance. If they are not available, we are not actually grade them. Okay, so in the next 30 minutes, not 30 minutes, maybe 20 minutes, we are going to discuss like 4 case studies, like starting from this one. So breakout session 1 will do this, like a case study or page 68, then you continue. Group 2 will be like the next case, that is page like 74, 68, page 74, then you continue like that. Group 3 will be the next case studies. So for 20 to 30 minutes, you'll discuss in the breakout room, then you'll give us like a feedback. So 20 minutes, then 40 minutes will be for discussion. At 11, you are going to do the group activity. So is it in order? I make the breakout session. Okay, let me do the breakout. So we'll have 5 groups. Then you can join.
Failure because of the edema, and then we also say that heart failure is also characterized by pulmonary edema, which could explain the difficulty in breathing
breathing and coughing and wheezing, and also other symptoms like orthopnea and all that. And then the history of presenting illness, we saw there is a cough on and off, labored breathing, and pedal swelling. All these are indicative of the different edemas here. For past medical history, we saw that she didn't have any past admission, no history of surgery, but however, she had HIV. That's why it's saying there retroviral disease, and she had missed her dose. So she was on a typical HIV regimen of lamivudine, efavirenz, and tenofovir, and she was also on other cotrimoxazole. Yeah. Medication history, those are the antiretroviral drugs she was in. She had no drug or food allergy. Yeah. Yeah. Now this is where we got confused. We saw that the blood pressure was 104/66, like that, decreasing with large intervals. So we weren't sure why there was an abrupt drop in blood pressure. Then we saw the pulse weak irregular. I don't know what, we were confused with that, what that statement means when you say a pulse is weak and irregular. And then we saw this chest as apex beat displaced at the 6th intercostal. This is normally indicative of, we Googled and we saw it's normally indicative of cardiomegaly, which is a common outcome of heart failure. Yeah. Okay. Yeah. Then for respiratory system, we saw cough on and off. BP, we saw again it's 104/66, then again 92/68, which is extremely low. And then we saw PO2, that one, saturated oxygen, 89%, it was very, very low. Normally it should be at least 96, 98 there. Then we saw pulse is 121 per minute, which is high pulse. So that contradicted the statement above, which said the pulse is weak. Yeah. And then we also saw respiratory rate is 28 beats per minute, so it was kind of high. We concluded that is hyperventilation. Then we saw bilateral cause crepitations. This will be as a result of the fluid accumulation in the lungs, or which could cause those sounds, or even other respiratory or pulmonary condition. Then we say the GIT is normal, abdomen is soft, which is normal since there is no tenderness and there is no hepatomegaly. Then we said the patient is postmenopausal. Then for the skin system, there was nothing recorded. Then the investigations done for our urinalysis, normal electrolyte levels, gene expert test for TB, chest x-ray, which showed cardiomegaly. And we said the investigations were probably not enough, since after you diagnose the like other ways of investigating heart failure, there are more. Like there are those others. I forgot. Then we say the problem risks are those ones, RVD, which is retroviral disease, edema. Now the person here wrote hypertension, yet we saw hypo. And then we saw, I don't know why they wrote asthma, then we saw orthopnea. And we weren't able to go do the current management, but we saw there was oxygen mask, for which is non-pharmacological. Then pharmacological, we saw the Lasix and allopril. Those ones were probably because of the high blood pressure and also because it's heart failure. And then we also saw the antiretroviral drugs at number 6. And then we also saw the person is also on Ventolin, which is for asthma management. And this is where we reached. Yeah.
Okay, thank you so much. You really normally had like a good discussion, like from your presentation. Huh? Okay, good. So, like, what is your opinion? Maybe I think let me give a chance for the group members to comment about the current management of the condition. So, do you think it is appropriate? Can you comment about the management of the patient?
I think for the Lasix is to reduce the water in the fascia and the legs where there are swellings. And then the Septrin and the ARV drugs are for the previous disease that he was having since 2018. And also, I think for the carbadirol was because of the heart failure.
Okay.
Yeah.
Okay, fine.
I had a confusion.
Yes.
Her blood pressure readings, they were lower than usual, and they've indicated in the problem list that they have hypertension, and there was no indication from the blood pressure readings that there's hypertension.
No, this one is hypotension. That means most likely the patient has taken like excessive dose of the Lasix intravenously. So at this point, by the way, what they can do is they hold the treatment. Then after that, when the BP is actually coming up, then they start actually like add like the patient will start the medication. So this is hypotension, not hypertension. By the
So the hypertension is because of excessive use of medicine.
Yeah, most likely. From my observation, it can be that is the most likely cause of hypotension from this patient. Lasix 40 milligram IV, yeah, that is the most likely causes. Okay, from the current condition.
Oh, and the ceftriaxone, as you said before, is prophylaxis because
most likely, yes. So because have you seen like from the investigation any sign of infection? I've seen bilateral course cryptation. There is something that shows cough on and off. That is could be because of the heart condition. So
there were no blood readings, so we couldn't tell whether there's an infection.
So yeah, there is no. So most likely, how is the presenting complaint? Was she like severely heart failure?
No, they only had swelling and dyspnea.
There is an edema of sure. That is why the diuretics are well in the regimen. So for me, it could be either prophylaxis or just like a common trend of giving ceftriaxone like without any indication. Yeah, that could be either. So I think the whole idea is like in the future, when you're actually going to, when you practice or when you are going to the practice area, you have to note really like the rationality of the treatment. So the only condition we can give ceftriaxone without having any signs and signs and symptoms of infection is in severely ill patient when they are at high risk of developing infection. Maybe we can give, but of course this is actually an immunocompromised patient, so the tendency is actually very high. But still there is ceftriaxone. Septrin can actually even prevent from developing several infections. Yeah, this cotrimoxazole. There is, I don't think so about the rationality behind that, despite we don't have like the full information about the patient parameter. Okay. Yes.
There's something I've noticed. I don't know whether I'm the one who's just noticed. Just go up a bit at the beginning. Up. In the beginning of the case study, could it be that he started getting all this as a result of stopping his dose? Like he missed his dose for 1 week here. You see, like we're being told the presenting complaint here for 1/52. I think that means for the last 1 week. And then we've been told that she missed her dose for 1 week. So could we say that by virtue of her missing the dose and she's immunocompromised, then it exacerbated her, like it just made her get sick, the heart failure just to come all of a sudden and all that?
Yeah, yes. Oh, they missed like the treatment for hypertension for 1 week, huh?
No, for HIV.
Okay, for HIV, of course, by the HIV can affect even the heart. It can actually even causes, is it cardiomyopathy? Yeah, there is HIV-induced cardiomyopathy, which is very common. But missing her dose of ARV for 1 week might not necessarily increase like sudden progression of the disease. Despite HIV can cause like heart-related issues, but what really causes like sudden swelling, partial swelling, will be maybe missing the dose of like the heart failure treatment management. It's very, very unlikely. But because this one, it can actually increase the viral load, but yeah, it's very unlikely, Annette, in this condition.
Okay, thank you.
Okay, so another observation, they have done gene expert like, but activities, we don't know the result. Huh? Okay, there is something Annette mentioned about the chest apex beat displays like the 6th intercostal, but the normal beat is the apex beat is like the 5th intercostal space. So like any displacement is usually happen when there is cardiomegaly. So that is normally they notice not during the investigation, but mostly they do it when they have the chest X-ray result. Okay, so so are you comfortable about treatment of this condition? So like, is it rational to initiate beta blocker when the patient is edematous? The patient is actually having edema, so and they started Lasix and even Carvedilol. So do you think it is rational to initiate both at the same time when the patient is having like massive edema? What is your opinion, the group members?
I think, well, I'm not sure, but in my opinion, I think the Lasix should be initiated first so that it can reduce the edema, and if I remember correctly, well, it can also be used as the first line management for hypertension because we know it is directly related to blood volume. So in my opinion, I think the Lasix should be introduced first before we initiate the use of Carvedilol or the, yes, because it could also inform on the dosage to give because we can tell how much hypertension has been managed by the diuretic before we initiate the therapy.
Exactly. So most likely, okay, despite the student they mention like all at once, maybe they have to indicate it, but most likely the Lasix has been given initially when the patient is condition is optimized, like the difficulty in breathing. That is when you are going to initiate beta blocker. Otherwise, it can worsen the condition. But the enalapril, I don't have any objection about the ARBs because they are cardioprotective. But the first thing what we need to manage in this condition is normally difficulty in breathing because of fluid accumulation. Then another observation I had, the dose of carvedilol is not correct. It is usually twice daily. 3.1 to 5 milligram POBD. I don't know whether you have noticed. Then we titrate every like 2 weeks up to the maximum dose. Okay, then what about the ART regimen? So do you think it is rational to give TDFs, RTZ, efavirenz with the current evidence? Will it be an effective regimen for the patient? Yeah, that is very important as well. Yeah, we don't forget, like when you look at the condition, you have to look at every parameter together, not the aspect of heart failure alone. So do you think the regimen is like the preferred regimen with the current guideline?
I think it is. I think it's the one which is HART or something like that.
HRT.
I think it's the standard combination in most hospitals.
This one TDFs RTZ efavirenz or the other one?
Let me remember. I don't remember.
Oh yes, that is why I gave you time. You know, you might not remember all at once, but when you are actually when someone gave you a breakout session, yeah, you have to Google and check. This the latest regimen. What about the Kenyan guideline? So you need to have all those information at your hand so that you can actually even look. Like one student will check the regimen of the heart, the other student will check about other medication. So you divide activities, then you share each other. That is the importance of like this breakout session. So anyway, any other person? Any other person? What does TDF stand for?
Tenofovir.
3TC?
Lamivudine.
AFV?
Efavirenz.
Okay, good. But nowadays, this regimen is not really commonly used. Why? Because in the first place, I don't know whether you have seen the latest WHO guideline 2019. I think 2019 is the latest one. So TDF-3T efavirenz was first line, but after the advent of the DTG, dolutegravir, the integrase inhibitor, like that regimen is like more effective. And even the study done in the Botswana and even in African population, it was actually like more effective, and you are going to achieve like a very complete viral load suppression and so increase in CD4 count. So because of that reason, nowadays, almost all patients, unless a contraindication, like TDF, CTC, and dolutegravir DTG is the most commonly used regimen. And it is usually given in the morning hours. So why, do you know why TDF, CTC, and DTG is given in the morning? I was wondering, I hope you have covered about ART with Larry, because he was just the one who taught you about the infectious disease component.
Is it probably because of the vivid dreams that comes along with it?
Which causes vivid dreams?
I'm not sure, but there's one ARB that causes nightmares.
It is efavirenz which causes a nightmare. So let them dream at night. That is why we give, this regimen is usually given at night time because of the CNS effect of the efavirenz, and usually given at night. But now when you give TDF, CTC, and DTG, the best time to administer it in the morning. But do you know why we give this regimen in the morning? Yes, but next week, next week we don't have because of the midsem. On week 8, you'll tell me, you read the heart guideline or HIV guideline in Kenya, then you will give me an update about that. Yes, I will actually even set few questions like a pretest before the class, and I will actually know whether you have read or not. And week 8, I will send you a reminder in the WhatsApp group. So do you know why we give in the morning? But let me answer this question first before Tiffany, Favan, what is your opinion? Or you don't?
Does it cause insomnia or something?
Which can cause insomnia?
The TDF.
Yeah, the DTG is the one which is actually known to cause insomnia. That is why if a patient is actually taking TDF, CTC, and DTG, you need to advise them they are supposed to take in the morning hours because of insomnia. Yeah, so that is the best time when you are going to administer. Then in week 8, you go and read about the HIV treatment guideline in Kenya, and read about even what about the use of TDF, CTC, and DTG in pregnant ladies. Yes, you just find out, is it recommended in the pregnant ladies? What are the latest information? Is it like DTG is teratogenic? There is something related to the neural tube defect of DTG. So you read and find out, then you will tell me when you come back, when you resume in week 8 after the midsem. Okay, then Ventolin, I think it is a straightforward. So you have to know, you have to give proper instruction, by the way, how to administer inhalers. Yes, yeah, you tell them to check. Can someone show me, give me proper instruction how to take this Ventolin puff? Just brief description. Hypothetical, we're assuming we're actually giving instruction to the patient.
I can try.
Please, Sylvia, okay.
First, you shake the Ventolin inhaler. Then you breathe out deeply so that you can put now the mouth of the inhaler inside your mouth. Then you puff. Then you don't breathe out in like 1 second so that the drug can get into the lungs. Then after that, you need to gargle your mouth. Yes.
Okay, good. Any compliment? Maybe is there anyone who can actually like compliment what she said? Okay.
The patient should be seated.
Seated position. They can stand. I think that one is not an issue. As long as you know what is most important is like proper fitting of with the lip, like during the inhalation. That is very important, by the way. And they're supposed to breathe in, like for and hold, like for 10 minutes. After dosing, they have to hold like the mouth for 10 seconds, a minimum. Yeah, before they start breathe out. That is very key, by the way. Then, if a patient is actually taking a steroid, they are supposed to rain their mouths after dosing. That is very important. Otherwise, they can actually develop oral candidiasis because of the local effect of steroids. Yeah, it's very common, by the way. So proper inhaler technique is very, very important, because if there is a failure, there is actually missing dose and improper treatment, which affects the treatment outcome. Okay, good. So I think you can actually revise, but anyway, this is how heart failure is treated in the practical setting. Oh, now we are 10:47. Okay.
Excuse me, sir.
Yes.
At what point would you give digoxin?
Or digoxin is usually given when a patient is having atrial fibrillation. It is very good, by the way. In case if they develop atrial fibrillation, you can consider, but like the more advanced the disease are going to include, you actually give the neurohormonal blocking agent initially, like the ACE inhibitor, beta blocker. Then after that, usually in stage D, like in a stage D, like in the refractory condition, you have to include even digoxin, like the inotropic agents in the treatment regimen. Otherwise, it's not really very common regimen in heart failure treatment, unless the patient is having that condition. So mostly in the refractory condition, stage D. Okay, any other question? Yeah, I like normally like your discussion now. I think that is why I like. Now I realize this breakout session is very important. Okay, good. So I don't know, in the next 10 minutes, can we see at least one other case, then you go to another breakout session for an hour? Can we do this like this one at least, second breakout? Oh, it's still congestive cardiac failure, the same thing. Okay, maybe let us see if there is any difference. Then the other group we can retain for the next time. Okay, group 2.
Okay. Hi. So, patient working diagnosis was congestive heart failure, cardiac failure, and then the presenting complaints were cough, difficulty in breathing, easily fatigued, and lower limb swelling, which are all suggestive of the congestive cardiac failure. And then the history of presenting illness, they were fine until 1 week ago, where they were easily fatigued without straining. And then they coughed and they were also having difficulty in breathing. So past medical history, we saw that they were admitted in 2012 due to congestive cardiac failure. And there was no surgery, no history of bleeding time, or no chronic illness, or known food and drug allergies. So when we saw the medication history, there was no medication history, which we found not right, because the patient had chronic cardiac failure. So we didn't know why there's no medication history. There was no drug or allergy. And then cardiovascular system, there was increased jugular venous pressure, which is usually seen in right-sided heart failure due to fluid overload. And then they had an irregular pulse of 124 beats per minute, which was tachycardic and no murmur. So respiratory system, there was a productive cough with occasional hypothesis, and the productive cough is due to the fluid overload in the lungs due to when there's backflow of fluid, and hence, yeah, there was also coughing of blood when the fluid accumulates in the lungs. Then the GIT tender hepatomegaly, we also saw this because in congestive heart failure can also cause blood to back up into the hepatic veins, and these are the veins that usually help drain blood from the liver. And when they back up, the liver will become congested, hence they grow larger. That's why there was hepatomegaly. Then the genital urinary, there was no disorder. Skin, eye, and intergumentary system, the jaundiced eyes could be explained by the liver. And then investigations, those are chest x-ray done. There were no results, urine analysis, liver function tests, there were no results. Then there's ECG, which showed sinus tachycardia, and sputum test, there was negative RFD, where confirms pulmonary TB was negative. Then under the current management, we saw that Lasix was given, and that can be given for the heart failure and for the edema, I mean, because it's a furosemide. And then paracetamol was given, but I don't know the reason why, because there's no fever or pain reported. And ranitidine, which is a H2 blocker, was given because it's used as a prophylaxis for acidity. And the enoxaparin, which is an anticoagulant, was given because patients have a higher risk of thromboembolism. Patients with congestive cardiac failure, they have a higher risk of thromboembolism. So the fluid intake and output was measured. They were propped up in bed because to enable the patient to breathe well due to the lung congestion. Because of the fluid overload. And then monitoring the BP and pulse rate. We felt that we could also add beta blockers because of the high heart rate, but we weren't so sure if it would precipitate more of the cardiac failure because of failure to beat out the fluid from the heart. And we also said we could also use digoxin as a second line treatment.
Okay, good.
Yeah.
Good observation. So it seems like this treatment protocol is comparatively better because they are giving only Lasix. But then when you see the word congestive, so they put the word congestive when a patient is having significant fluid accumulation. Yes. So this patient is actually having fluid overload, or fluid accumulation. Have you seen even the dose of Lasix, like 120 milligram IVTDAs? This is very high dose of Lasix. In fact, even electrolyte monitoring is very important with this dose. That is why, in fact, monitoring of BP and pulse rate should not be it should be under the monitoring parameter in ways. So ranitidine 15 milligram, this is not 15, it is 50 milligram IVTDAs. It is I think it's just like typing error. Enoxaparin is just as a prophylaxis. By the way, 40 milligram subcutaneous is the most common prophylaxis dose of enoxaparin. I think those are the only. Do we have any other low molecular weight heparin in Kenya? I came across only enoxaparin with the brand name Plexen. It might be available, but this is the most commonly and widely available low molecular weight heparin. So this is the prophylaxis dose, 40 milligram subcutaneous OD. Yes, okay. But the rest, as she explained nicely, that is why they have mentioned there is jaundice or eye test. Despite we don't have jaundice eyes, the eyes are actually become very yellow. That is why we need to do a liver function test is very, very important. So the only result we have is having ECG and pulmonary TB test. Otherwise, we don't have any lab result, which is very, very important. So PCM is most likely just to prevent, maybe, I don't know whether the patient is having any pain, musculoskeletal pain. I think paracetamol is the safest analgesic. Yeah, easily fatigued without, so most likely the patient was having some kind of pain. So that is why they give paracetamol. In fact, it is safest, but it is the most commonly abused painkiller as well. Yeah, especially for the patient who is having jaundice eye, and if you give them paracetamol 1 gram TPS, you can see the hepatotoxic dose of paracetamol is in normal patient, if you give above 4 gram, the risk outweigh the benefit. That is the maximum dose we can give. But if a patient is having underlying liver problem, in fact, even we have to give like up to a maximum of 2 gram daily dose. Otherwise, we can increase the risk of hepatotoxicity. So, okay, we don't have the result of course, we can't comment at the moment, but it is good to like watch out when a patient is having any liver problem. Of course, the liver problem is actually as a result of the heart failure because of reduced perfusion to the liver. But of course, we need to like watch out properly. Then bed prop-up is a common, if you go to like the internal medicine, what does they say? Like hypertensive patient, mostly their bed is prop up because they cannot breathe properly. To prevent autopnea, mostly they have to have like a proper bed, which is very common. So if you see like proper bed, most likely those are acute patients, or maybe they're not actually responding well for the treatment or acute patient. So that is why proper the bed is one of the treatment modalities for this condition. So when the fluid status is actually stable, now that is when we are going to initiate. We are going to initiate what? The beta blocker, the ACE inhibitor. Okay, then ranitidine, most likely stress ulcer prophylaxis. That is the most common indication. I don't think, in fact, we don't have any, do we have any information about the GIT, tender hepatomegaly only? Okay, no peptic ulcer disease history. How old is the patient? Do we have the age of the patient? Oh, I didn't copy that component. Okay, okay, fine. So anyway, this is all about the patient, despite the information is not complete.
Excuse me, sir.
Yeah.
Can we add beta blockers to the list of medication?
Not now. When we have to make sure the patient is actually stable and evolemic before we initiate. Otherwise, with this, we cannot initiate because the patient is having an edema.
Okay, thank you.
Yes. Okay, any other?
And digoxin, can it be used to increase, like improve heart failure symptoms?
It can improve, but it is not like the front line, the management. So like we have to start with the primary treatment first. So if we don't respond, we are going to add digoxin. But remember, digoxin is very effective when a patient is having like systolic heart failure. In fact, that is the most common type of heart failure. But in diastolic failure, if the problem is just relaxation of the ventricle, it does not help because digoxin mostly in heart failure management, the importance of digoxin is just to promote contractility of the ventricle. So it has a benefit, but it's not in the front line in the management because of the toxicity issue. Okay, any other question? Okay, now this is like the end of the session for today. But in the next an hour, I have I think I did one case studies with 2 questions. So in the next an hour, you have to do, then you submit it on Blackboard in the span of like up to midday. Then after midday, it will expire. So you can call other 2 students. I think 3 students are not available. So look at your group on the Blackboard. Then you submit it immediately. Someone can type after discussion, then you submit. Then when you are submitting, by the way, I think there is, some people normally do an individual submission, but it is a group submission. I don't know, can you actually discuss how you are going to submit? Because I don't really, I've seen one student, they submitted like the group assignment as an individual assignment. So maybe discuss with some other group members, then you have to actually submit as a group, not an individual, so that when I'm actually marking, I can see the list of all the students from the grading section. I don't know whether you understood what I said.
Sir, do you mean that we use the group link when we're submitting so
Yes.
that you get the names?
Yes, please. Exactly.
Okay.
Please use the group link. Okay. Fine. I think you can proceed. And thank you so much for your active participation.
Where is the case study posted?
It posted in the group, in the assignment section. Can you check, please? Maybe someone can check. In the assignment section, you'll get it. And now, by now, it should be active. Yes, if you do have any issues, maybe you can send me an SMS. You send me a text message in WhatsApp. Yes, in case if you are not able to see it, but I don't think so. Yeah, now it is active. You can proceed.
Groups.
Sir?
Yes, yes.
Are we typing the work in the discussion component and submitting it, or
you just
exactly
submit,
how are we doing it?
Yeah, you just submit normally like the question only. It is just A and B, then you submit like you just type the answer only.
Okay.
Yes.
So we leave the meeting and go do the work, or how are we going to do it?
Okay. Can you? Okay. I think you have to make your own group, or I give you a breakout session. I don't know which way do you want to do the assignment.
Is it possible to make a breakout session with just the members of the group?
Okay, fine. If so, what I can do is I make a breakout session of 6 group. Yeah, it is 6 group. Hello.
Yes, we can hear you.
Okay, then what I will do is let me recreate the breakout session. I make it how many group? I think 8. 8 breakout session. But can you choose your room based on your group? I think that is the only option. Yeah? You check your group on Blackboard, then I can actually create the group, recreate the group. So let participants choose a room. It's how many group? Like 6, 6. We have to have like, how many groups can we make? Let me make 6, 6. It should be like 12.
But you see, sir, the challenge with that is, see, group 3 for group B is different from group 3 of group A, right?
Yeah.
So you see now, like at the end of the day, you want individual groups. So will the group B of group 3 of group B and group 3 of group A combine, or just individual?
Yeah, that is why, because that is why the Blackboard is in different class. That is why I'm requesting if you make your own Zoom on the, or I don't know.
I think some people can make their own groups and do the work and just submit.
Yeah, yes, I think that is the easiest way, by the way. Just make your own group, then you actually submit.
Yeah.
Yes, I think that is the easiest way. Okay, Sawa. Thank you.